Thank you, sir. Good morning, everyone.
We have a pencil or pen here.
At the outset, I'd like to thank the organizers and especially Puneet sir for giving me this opportunity. I'm Dr. Milap Shah from Ahmedabad, and I'll be presenting on the paper the DaBlaCa-13 Study, short-term intensive chemoresection versus standard adjuvant intravesical installations in NMIBC. So we all know NMI patients experience recurrence every year up to 15 to 70%. And to secure early detection and timely treatment of recurrences, an extensive follow-up program for the bladder cancer is recommended. Recurrent NMIBC is treated with TURBT, typically followed by adjuvant installations with MMC and or BCG. The need for the study highlights a few points that the treatment is costly and associated with few side effects. The TA tumors definitely have a low risk of progression. And there is always a lacunae in terms of treatment when considering the elderly, the multimorbid patients who often show poor tolerability of anesthetics and operative treatments. To evaluate the tumor response of short-term intensive chemoresection of MMC in both high and low-grade recurrent NMIBC, and to compare the adverse events of the regimen with the adverse events of the standard treatment, that is TURBT followed by adjuvant installations, were the aims of this particular study. This was an open-label randomized control trial. Randomization was 1:1 using the REDCap software, and it was conducted from January 2018 and to June 2019. 120 patients were enrolled from 2 major urological centers in Denmark. Out of the 357 patients assessed for eligibility, 237 were excluded based on the following criteria. The inclusion criteria included patients having history of TA low-grade or TA high-grade upon recurrence with more than one tumor, patient population having an intermediate or high risk of progression, papillary tumors with a diameter up to 2 centimeters, and there was no upper size limit for the flat lesions. Exclusion criteria included the BCG treatment within the past 24 months, previous treatment with MMC except a single shot installation, suspicious of carcinoma in situ or invasive or solid tumor, patients with incontinence, acute cystitis, pregnancy, or breastfeeding females. In the intervention group, MMC installation was done 3 times a week for 2 weeks. There was a 2-hour dwell time with at least one patients having at least one installation required to be included for the analysis. And the tumor response was evaluated by flexible cystoscopy at 4 or 6 weeks after the final installation by a single doctor. Now on flexible cystoscopy, if there was no residual tumor observed, it was termed as complete response. If there was tumor shrinkage observed, a second flexible cystoscopy was performed after 4 weeks. And in case of no residual tumor, it was termed as complete response again and kept on follow-up. If the same residual tumor was observed on flexible cystoscopy, then a biopsy, fulguration, or a conventional TURBT was performed. And in case of benign histopathology, it was termed as complete response. And in case of malignancy, termed as incomplete response. The non-inferiority power calculation was based and assumed on the previous 2 studies that at least 50% of the patients in the intervention group would experience a complete tumor response. Assuming equal recurrence rate in both groups and equal recurrence risk in patients with or without complete tumor response in the intervention group. And based on a primary endpoint as a number of patients in the need for a TURBT, a difference of groups of 25% and alpha of 5%. In the 2 studied tests, 54 patients were required in each group. Expecting a 10% dropout, 120 patients were enrolled, and the non-inferiority limit was set at 5%. Statistical analysis was done using for the categorical data by the Fisher's exact t-test, and multivariable and univariate logistic regression analysis was performed. Even the adverse effects were analyzed, and the differences were noted in percentage. Coming to the results, out of the 58 patients in the intervention group, 33 patients showed complete response. Out of the 25 patients showing an incomplete response, 22 were low grade, 3 were high grade. Coming to the tumor size, patients with less than 5 mm of tumor size and more than 20 mm of flat lesions showed a better response in terms of installations, but this was not reflected when multivariate regression analysis was performed. Similarly, patients having more number of recurrent tumors had better complete response rates. Same was when patients were seen having higher number of previous recurrences and patients who were active smokers as compared to the former smokers. No differences were noted if in case of prior histology of low grade or high grade, history of prior BCG treatment, or the tumor localization. Coming to the adverse events, here also the intervention group fared better. There were no grade 4 adverse effects reported in either of the groups. 3 grade Grade 3 adverse events were reported, 2 cases of cystitis, 1 in each group, and 1 case of fever in the control group. In terms of dysuria, increased frequency of urination, Palmer skin rash, hematuria, and incontinence, all these factors were noted more in the control group as compared to the intervention group. Now, previous to this study, there were only two randomized studies of low-grade tumors. That was by Mustafa et al. And Colombo et al. There was no systematic review performed. Giving a brief overview of these two trials, in the first trial, at Colombo et al., there were 54 patients included, and a complete response rate was around 70%. In the Caliber trial, it was a complete response rate of around 37%. In this particular study, a complete response rate of 57% was noted. However, a non-randomized study, a retrospective study, was taken into reference, and it showed that if the evaluation is prolonged for up to 45 days, then a complete response rate is much more improved. And in this study as well, the evaluation at 4 weeks was found to be premature in 62% cases. And biopsy was not done to confirm the complete response. They used enhanced histoscopy to increase the evaluation accuracy. In this study, the risk of residual tumor was 43%, is comparable to the risk of residual tumors for TA after TURBT. 85% of patients experienced tumor shrinkage, which resulted from a comprehensive TURBT to kind of a minor TURBT or even outpatient tumor fulguration. A few questions. Risk of overtreatment. Yes, being a neoadjuvant design, there is a risk to treat patients without neoplasia. MMC can be more effective in high-grade tumors because the high-grade tumors undergo more mitosis than the low-grade tumors, but long-term follow-up is required to prove this. And the acceptability definition can be absence of any significantly different risk of recurrence and progression in these two groups. The limitations being an open label design, lack of adverse events, follow-up data of participants in the control group who did not receive adjuvant instillations, small proportion of patients who had received BCG prior to the inclusion. One of the main reasons of the last mentioned limitation is the exclusion of the carcinoma in situ patients who are the primary target for BCG in Denmark. According to Danish guidelines, they recommend MMC and BCG to be considered in intermediate risk patients, and the use of adjuvant BCG alone in the control group could have introduced an inherent bias. To avoid this bias risk, adjuvant BCG could have been initiated in the intervention group after complete chemoresection, and this design was not chosen to avoid a second instillation treatment. Coming to the conclusion, for the patients with recurrent, intermediate, and high-risk TA and NMIBC, only half treated with chemoresection needed a TURBT. Chemoresection can be considered an acceptable solution for elderly and multimorbid patients for whom surgery is less desirable, and the treatment is associated with fewer clinical side effects. Owing to small numbers, further investigations are definitely required on TA high-grade tumors. Thank you.